So I know it's very late, so we are moving to the last topic of the day, renal issues and dialysis during ECMO. So I have nothing to disclose. We all know that ECMO is a life-saving procedures and for the reversible pulmonary and cardiopulmonary failure. But unfortunately, these patients are at a very high risk of developing acute kidney injury, especially patients who are undergoing VA and fluid one. So the use of renal replacement therapy during ECMO is mainly for the fluid balance and managing the metabolic derangement. And the incidence of AKI is as high as 75%. And once the AKI develops, if not treated aggressively, it is associated with the poor outcome. And those patients who develops acute kidney injury, almost 50% of those patients who are in the severe grade 3, they require renal replacement therapy at any stage of. So if you look at the AKI prevalence, there are certain limitations to these available data. These are single centers. There are multiple definition of AKI, and we have to rely on the ELSO database, whatever the data has been submitted. So in the neonatal population, they have found that it's almost 70%, and in adult cardiac patients, it is around 81 to 85. If you see the different criteria for identifying acute kidney injury, so initially it was Rifle's criteria, and which includes the acute phase, risk, injury, and failure, and the chronic phase, the loss and end stage uh, renal disease. So this is the level of injury. What we nowadays use it as a grade 1, grade 2, and grade 3 in the KDIGO guidelines, where the increased in creatinine and urine output is the criteria for to identify and level this acute kidney. So if you look at the ECIN criteria, it's almost similar. They have staged to 1, 2, and 3, and almost similar as we see the KDIGO guidelines. So it has been seen irrespective of the type of definitions, whether you look for the Rifle's criteria or ECIN criteria, the incidence of AKI remains same. Why these patients develop acute kidney injury? Because there is an imbalance between the factor which protect the renal function and factor which induce acute renal impairment. These are patient-related factors mainly. First, patient who is a candidate for ECMO is most of the time is critically ill. They are hypotensive. There is hypoperfusion. Lactate levels are rising. Blood pressure is low. So organ perfusion is compromised. Oxygenation is compromised. They are in the low cardiac output state. There is a systemic inflammatory response, and organ autoregulation is lost. So many times they are on the drugs which are nephrotoxic, and to maintain hemodynamics, we push too much of fluid in these patients who are doing a volume. And once the patient has been put on it, on one end, ECMO, VV ECMO improves oxygenation, so improves the patient condition, try to improve the oxidative metabolism, while on VA ECMO, which improves the cardiac output and tissue perfusion. So on one end, it is improving the perfusion. But unfortunately, on the other end, if the hemodynamic factors such as if there is a non-pulsatile flow, because VA ECMO flow is a non-pulsatile, that affects the organ perfusion. We rapidly try to reduce the vasoactive drugs, which can lead to a severe hypotension and compromise the organ perfusion. Or there's a downregulation of the natriuretic peptide. There is always some amount of systemic inflammation because of the foreign body. Blood is going against the foreign body, exposure to a non-self membrane, and there is a blood and air interface. And we all know very well about the organ crosstalk that if once one organ is compromised, it is going to affect other organs like cardiorenal syndromes or lungs and kidney interaction. And some circuit and flow related issues like embolism or hemolysis, if the flow is very high, it's all can start affecting the kidney over a period of time, including development of sepsis. So as the Rifle criteria increases, the chances of mortality keep increasing. And if we go for the A higher stages of the Raffles criteria, stage 3, grade 3, then mortalities may be as high as 100%. So the first attempt was made as a survey to look for what are the practices across the world in cases of renal supportive therapy. But unfortunately, in spite of so high incidence of AKI, what we have seen that hardly few centers have some protocol or they are using any structured use of the renal placement therapy or renal support therapy. So the most common indication what they found was the fluid overload for fluid removal, the use of CRRT. Which mode people are using? There is no standardization for that. The most common was the SCUF and CVVH, and almost one-fourth center did not use renal placement therapy during ECMO at all. So the common indication includes fluid overload or fluid overload prevention, uremia, acute kidney injury, and electrolyte disturbances such as hyperkalemia. So what are the benefits if you combine ECMO and CRRT or any kinds of renal placement therapy? Especially the CRRT, which is going to done over a period of 48 to 72 hours for a long time. It helps to manage the severe lactic acidosis. It helps us to avoid fluid removal slowly so that the hemodynamics is not affected and we can take out the good amount of fluid. And improves the lung function once the fluid is removed. It improves the cardiac functions, less myocardial edema. We can administer adequate nutrition, blood and blood product, and it helps us to reduce the surge up to a certain extent. So we all know that effect of fluid overload, um, it is associated with a poor out. So this study clearly mentions that if the um, fluid survival is much better if the fluid overload is less than 10% of initiation, while if it's more than 10%, the chances of survival decreases significantly. So when to start the renal placement therapy on ECMO? The timing is still not well defined. It should be look at the individualized method. However, it has been seen that the early initiation of CRRT is associated with the better outcome because if you delay the mortality is very high because by that time the organ damage sets in and it reaches to a irreversible state. So what options we have for the renal placement therapy? It can be continuous. When we define continuous, it means it's more than 24 hours continuously. So it can be as a CRRT or even the peritoneal dialysis, which can be continued for even 48 to 72 hours. And intermittent therapy in the form of intermittent hemodialysis or slow low efflux dialysis. So all these modalities have the different benefits and its complications. Like intermittent hemodialysis, it can be connected with the ECMO. It reduces the downtime, lower cost as compared to the CRRT. But definitely, you are doing it for a shorter time, so you have to take a lot of fluid at a very short period of time, which can cause hemodynamic instability. There is a risk of disequilibrium syndrome, and there's a potential risk of septal edema. And definitely, it needs more complex. If we do the sled, definitely again it can be connected. The duration is bit longer, so the risk of hypotension is much lower as compared to IHT, and it removes the volume slowly. But yes, it is again technically a bit complex and it needs additional technician for it. CRRT, it can be connected. We can do continuous removal of fluid and uh, other electrolytes and other toxic materials from the body. It will help us to, though it takes out smaller amount of fluid per hour, but if we compare it after 48 or 72 hours, it takes a good amount of fluid. But the problems associated with the CRRT, like immobilization, which is itself on ECMO patient is immobilized, or there is a risk of hypothermia, which we are already controlling. And again, if we talk about the cost, the ECMO is a pretty costly procedure as compared to the CRRT. Peritoneal dialysis, it can be done because it does not affect hemodynamics much, but patient is on heparin, so one has to be careful for doing the peritoneal dialysis in this patient. However, in pediatric population, it is a good option to do a peritoneal dialysis. What are the modes? We have four modes what we use in the CRRT: slow continuous ultrafiltration, continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, and continuous veno-venous hemodiafiltration. So what we do with the stuff in a stuff, we just take out the fluid, where no, it's only for the volume control. You are not taking out any solid. Blood flow you usually keep ranging from 50 to 2. When we talk about a CVVH, it's basically a convective clearance where you take out the metal molecules. And so those are some inflammatory in the initial phases, some inflammatory markers also comes out, where you provide replacement fluid in the pre and post uh, the filter positions depending upon the need, and you can adjust the doses so that you can increase the filter time um, with the adjusting these pre and post filter fluid. CVVHD, it is basically diffusive as it is for the conventional dialysis, and you can use a dialyzer ranging from 15 to 60 ml per minute. CVVHD, it is basically a combination of diffusive therapy and convective therapy, where you use both replacement and dialyzing fluid, and here you take out the small as well as the middle volume. So how to do it? How we can do? We can do a separate venous access independent to the ECMO circuit, where those circuits do not interfere with each other. We can use the inline hemofiltration filter with the circuit itself, as we do during the cardiopulmonary bypass. It's very cheap because you are not using any extra circuit for it. Or we can include a CRRT machine directly to the ECMO circuit. So individual methods has its own benefit as well as some disadvantage. So if you are using an independent access, which you can see here in this patient was on CRRT and later required the ECMO support. So we have put a left femoral cannula and the right internal jugular. So the advantage, there is no interference because both can affect the hemodynamics of both circuits, and this can lead to a compromise in the ECMO circuit, which is pretty costly. But if you are putting it separately and after the initiation of ECMO, there is a more risk of bleeding, and you are losing one vascular access if in case you need another access during the VBM. Inline filter, this is can be connected between these limbs. You can see here, inline filter can be connected. You can see it has been connected here. It is cost effective, very quickly can be adjusted, and you can use the low blood volume. You don't need higher prime volume. But to add the therapy like a CVVHD or CVVHD, you have to add the dialysator replacement through the infusion pump. So the accuracy definitely will be compromised. However, it will be a pretty cheap. The third option is you can add CRRT machine in the ECMO machine itself. For that, you should know the different pressure. So if you talk about the pressure, we all know that the pressure before the centrifugal pump is the negative pressure. After centrifugal, so this is the first thing you should remember. The second thing you should remember that the pump, the pressure beyond the pump is always positive, and anything going beyond the membrane oxygenator will go to the patient. You don't have a control to stop it. So there are, and you can connect, there are different combinations where you can connect your CRRT machine through the in the ECMO circuit itself. So the advantages is to set up, you again use the less blood volume and less resource intensive, but the problem is both these extracorporeal therapy can interfere with each other, because still now there is no CRRT machine which can be acclimatized with the ECMO circuit pressures. So let's take one by one. Here you can see this is the access line and this is the return line which has been placed pre-pump, pre-roller. So this is one combination. It has its own advantage and disadvantage. So there is no resistance to the outflow, the advantage, but the problem is you can keep getting a low pressure alarm during your CRT. So you should know when to override these. Another combination which is being commonly used between the pump and oxygenator as an access line, and the return line is at the pre-pump position. So this is another combination which is quite popular. The advantage is good inflow to the CRT circuit, so there is no resistance in outflow from the CRT circuit. But again, it can trigger too high pressure on the access line in the CRT machine and low pressure on the venous line. The third combination, you can use both after the centrifugal pump. So again, this is a commonly used, and ELSO also recommend for these combination to put these lines post pump, because the advantage is the quality of dialysis will be much better because there is no recirculation. Though it is a very small, but still there is no recirculation. There no risk of air entering the centrifugal pump, and oxygenator work as a air trap, bubble trap, so air cannot go beyond oxygenator. This is another combination. However, it is not recommended that you use the return limb of the patient as an access cannula, because this is the high pressure limb, and any air bubble during connection, are there any loose connection which can induce the bleeding, and you can use return line at a drainage limb. So advantage, the optimal inflow to the CRRT circuit, no resistance to the outflow from CRRT, but you have to be very careful, otherwise there is a risk of. This is very commonly used combination. Again, it's highly recommended. These all oxygenator, they have the port at a pre-oxygenator and post-oxygenator. So the access limb is connected post-oxygenator and return limb is connected pre-oxygenator. Why it is important? Because if there is a small air bubble or a small clot, that can be trapped in your oxygenator. But definitely you have to be very careful, because change of pressure or air bubbles or clot all can compromise the quality of oxygenator, gas exchange, because we know that the oxygenator is pretty costly. So this is another combination. The reverse one, that access, you can use a drainage limb and return you can use for the post pump and pre-oxygenator. This improves the quality of dialysis, but there are certain issues, including the hemolysis. So what are the difference between the RRT methods? Inline hemofilter, this has to be controlled through an IV pump, while CRRT machine is completely controlled and it provides a good metabolic control, and you don't require there is no systemic changes during this. So the complication of dialysis, irrespective of whether you use the CRRT or SLED or intermittent hemodialysis, there is a risk of hypovolemia. So you have to be very careful of the volume status. This can lead to a hypotension. There is always a risk of electrolyte imbalance, especially during CRRT. There can be hypophosphatemia, hypokalemia. All needs to be corrected, otherwise it can lead to arrhythmia or other issues. There may be a poor flow because of the inappropriate connections or loose connections or kinking of the lines, and definitely bleeding and thrombosis due to inappropriate heparinization. Machine related, because you are connecting two extracorporeal therapies together, so there is more risk of hemolysis or clotting and decrease in the pre-pump pressure. And if at the pre-pump level there is a loose connection, there is a risk of ARM. Renal recovery, the data is limited, but definitely the data is suggestive that early initiation of CRRT is associated with the better renal recovery, which has been shown in the several small case series or small studies. So you can see the impact of renal recovery, that almost 70% patient developed AKI and 47% required CRRT, which was more in the VA ECMO group as compared to the VV ECMO group, and early CRRT was associated with the better outcome. So to conclude, patients who are receiving ECMO, VA or VV, especially VA ECMO, at a high risk of developing acute kidney injury and fluid overload. Cumulative fluid balance, positive fluid overload is independently associated with a high mortality, because it compromises oxidation or leads to a prolonged ICU stay and requirement of the mechanical ventilation. In any ICU patient, irrespective whether we are using ECMO or not, the pathophysiology of the associated AKI is mainly related to the decreased renal oxygen delivery and inflammatory damage. Risk factor for AKI are associated with the patient's underlying disease as well as the ECMO-related. Almost 50% patients who develop the AKI may need some or the other form of renal replacement. There is a vast variation in management of AKI across the globe, and however, the recent evidence suggests the favorable outcome with the use of CRRT during ECMO. This can be both These extracorporeal therapy can be safely done in a variety of setups. No additional regional or anticoagulation is required since the patient is already heparinized. So far, there is no guidelines recommendations which particular technique of CRRT should be used or how to combine them. We still need to learn more what is the right time to start CRRT. However, early CRRT is associated with a better outcome. And we need a multidimensional evaluation and multimodal therapy because this should be integrated so that patient can have a flexible and patient-tailored platform for the multi-organ support. Thank you very much for your attention, and I'll be happy to answer if you have any questions.